Thank you.
Rest today, you can start.
Yes.
Okay.
So I'd like to welcome you all to our last session of this year of our monthly webinars. And today we have Professor Kwan who will be speaking on shoulder balance. We all have been waiting for this talk since the beginning of the webinar. So over to Dr. Ajoy Shetty to start with the proceedings.
Good evening to all of you. Today is one of the important session, a topic of great interest, because we identify most of our patients with scoliosis when they come, apart from rib hump. One of the common things they do come to us with is shoulder imbalance. And how not to have a shoulder imbalance following surgery is what is very important. We have with us Professor Kwan. I'm sure most of you do not need any, know him, and he doesn't need any introduction. However, he is a professor and a head of the spine surgery unit at University of Malaya, Kuala Lumpur. He is the past president of the Asia Pacific Spine Society and the Malaysian Spine Society. He is a prolific researcher, done a lot of work on adolescent idiopathic scoliosis, and one of his favorite topics is shoulder balance. Without any further wasting time, I would like to invite Professor Kwan to deliver his lecture. Over to you, Prof.
Yeah, thank you, Ajoy. So first of all, I would like to thank the Pediatric Spine Academy dear members, Dr. Ajoy, Dr. Abhay Nene, Dr. Appaji, Dr. Bhavuk, and Dr. KV, Dr. Pankaj, Amit, and Arjun for the invitation. Okay, the topic given to me today is shoulder balance in scoliosis surgery. No conflict of interest. So, as we know, the goals of scoliosis surgery is to correct the deformity, then achieve solid fusion with minimal morbidities for safety reasons. We try to feel shortest possible to preserve maximum function, and lastly, a well-balanced spine. This including coronal, sagittal, axial plane for cosmesis purposes. In the coronal plane, it's very important to make sure a good trunk balance, a good shoulder balance, and neck balance. And certainly, after scoliosis surgery, we would like to avoid a disaster like this, which is a post-operative shoulder balance. So therefore, we come to the topic today, a shoulder balance in scoliosis surgery. Before I proceed to talk about shoulder balance in scoliosis surgery, I would like to share some of the philosophy behind balancing something. Balance is not something that you can find, it's something that you create. For example, while you're performing balancing stone. As we know, when we perform balancing stones, there are two important elements in order to achieve the result of a balanced stone. First, we need the contact point. And once you got the contact point, we require a proper tube angle for the stone to balance. And if we look at scoliosis and balancing stone, the concept is approximately the same. For years, we know the contact point, both the UIV and LIV very well. So the question now is, how about the UIV and LIV tube angle? So what are the proper LIV and UIV tube angle? Today, we have publication from literature guiding us how to calculate this UIV and LIV tube angle. And in this lecture, hopefully, at the end of the lecture, I'm able to share with you this concept of calculation of the UIV tube angle to achieve a good shoulder balance. What is post-operative shoulder imbalance? In structural main thoracic curve Lenke 1 or structural proximal thoracic curve Lenke 2, overcorrection of the main thoracic curve will result of upward left shoulder. This will result in a post-operative shoulder imbalance. This is not something new. Winter have reported 30 years ago that overcorrection of main thoracic curve beyond the spontaneous correctability of the proximal thoracic curve will result in undesirable asymmetric neck along with the ugly trapezius prominence and shoulder contour. And today we know from meta-analysis, the pool incidence of post-operative shoulder imbalance is approximately 25%, 1 in 4 cases. And PSI patients have been reported to have a poor satisfactory outcome. Types of shoulder imbalance. At this point, we already have evidence from literature showing that there are 2 types of shoulder imbalance. Keong and colleagues are the first who describe the outer shoulder height and inner shoulder height in AIS patients. This concept was later popularized by Ono and colleagues, which had described there are 2 distinct types of shoulder imbalance: a lateral shoulder imbalance and medial shoulder imbalance. Lateral shoulder imbalance is reflected by clavicle angles, whereas medial shoulder imbalance is reflected by trapezial prominence, correlate well with T1 tilt and first rib angle. However, if you look at the medial shoulder imbalance and you extend the X-ray or the clinical photo upward, one will see there's another component called neck tilt. Our published data show that medial shoulder imbalance and neck imbalance has a significant correlation with T1 tilt and a new parameter called cervical axis. Whereas lateral shoulder imbalance is a totally different issue, which correlate well with clavicle angle and radiological shoulder height. So in summary, types of shoulder imbalance nowadays can be classified into lateral shoulder imbalance, evidenced by clavicle angle and RSH, medial shoulder imbalance, characterized by radiological parameter T1 tilt and first rib angle, and lastly, associated with neck tilt, where the radiological parameter is cervical axis. So let's relook the current recommendation for UIV selection in this group of patients. Numerous studies have reported the importance of the UIV selection in achieving a good shoulder balance. These are the published literature that commonly used to select the UIV selection. In the main thoracic curve, mainly lanky 1, T3 will be preferred choice of UIV selection, whereas in the proximal thoracic curve lanky 2, T2 will be preferred as a selection for the UIV. However, studies also show that UIV selection alone is not a definitive solution for preventing post-operative shoulder imbalance. Birch and colleagues have reported, despite using the existing algorithm that we discussed previously, the author could not identify a set of UIV selection that can accurately predict PSI. So these are some examples that I corrected. Post-operative shoulder imbalance can occur irrespective of the UIV selection. You can stop at T6, T4, even up to T2. Medial shoulder imbalance and neck may still occur. So what does it mean? It means that beside an appropriate UIV selection, there is another important factor which contributes to post-operative shoulder imbalance. I will start to talk about the prevention of medial shoulder and neck imbalance first. The importance of UIV tilt angle and how to calculate this UIV tilt angle before the operation so that we can use this optimal UIV tilt angle and articulate to prevent medial shoulder and neck imbalance. Amil and colleagues have reported that medial shoulder balance can be prevented by leveling the T1 and first slip angle. This can be achieved by maximum correction of the proximal thoracic curve. In our opinion, post-operative UIV tube play a very important role in leveling the T1 tube, as shown in these two radiographs. So Chan have published an article and has shown that post-operative UIV tube angle is an independent factor which has a significant correlation with post-operative T1 tube, which is medial shoulder, and post-operative cervical axis, which is neck tube. Deng and Scully recently have published 120 AIS patient, Lanky 2, and they noted that 70% suffered from medial shoulder imbalance, and the most significant factor that predicting medial shoulder imbalance is post-operative UIV tube angle. Our data show that if you have a post-operative UIV tube angle that tilted to the right, positive region, there will be increased 15 times odds of developing a positive right side medial shoulder imbalance and 3 times odds of developing a neck imbalance post-operatively. So this is some of the publication with regards of shoulder imbalance from the literature. As you can notice, all of this is as a result of the UIV being tilted to the right side in the conventional right. So the issue is how to solve this problem. Our published data show that if you can have an optimal UIV tube angle during surgery, achieve an optimal UIV tube angle during surgery, this can prevent the medial shoulder and neck imbalance, but not lateral shoulder imbalance. So the question now is how to calculate the optimal UIV tube angle before the operation so that we can execute this optimal UIV tube intraoperatively. The use of supervised cervical supine side bending firm can be used to calculate this optimal UIV tube angle before surgery. And based on this supervised cervical supine side bending firm, one can measure the right side bending angle and the left side bending angle. And using a simple mathematical formula, one should be able to calculate the optimal UIV tube angle. So this is an example of the supervised cervical supine side bending firm. The red color is the C7, whereas the blue color is the UIV. So from this radiograph, one can calculate from the right side bending and left side bending angle, referring C7 to the UIV. And in this case, the optimal UIV tube angle for T3 is -5 degrees, which means that tilted to the left 5 degrees. Let me show you with the short video, how do we come to this concept. This is the left side bending. When you maximum stress to the left side, one can calculate the C7 angle from the UIV. And this is a left side bending. One can calculate, again, the right side bending C7 above the UIV. So by knowing this right side bending angle, which is to the right 11 degrees, and left side bending angle to the right 1 degree, one should be able to measure the optimal UIV tilt angle. As shown here, the right side bending is plus 11 degree. Left side bending is to the right 1 degree. So in order to bring the C7 to the center of CSBL, the optimal tilt angle of T3 must be tilted to the left to bring the C7 to the center. And this optimal tilt angle is calculated as -6, mean tilted to the left 6 degree. This is an intraoperative feature, and we will try to achieve the tilt angle to be tilted -6 to the left side in order to achieve a good neck and medial shoulder balance. So now I would like to share the surgical strategy that used in our center with the illustration of 3 cases. Case study number 1. This is a classic lanky 2AL case, a 15-year-old female, main thoracic from 57 to 23 degrees, proximal thoracic 47 to 41 degrees. I looked through the literature and I found that a similar radiograph had been published, and post-operative, the similar case developed a severe medial shoulder imbalance and neck tilt. So these are quite a classic case that will result in the severe medial shoulder imbalance. So for this case, the UIV selected by us is T2. So how do we calculate the optimal UIV tilt angle T2? So based on the calculation, right side bending is to the right 2 degree, and left side bending is to the left 2 degree. So therefore, the optimal UIV tilt angle for this case, our case, should be at 0 degree. So which is good news because it's easy to achieve a 0 degree UIV tilt angle. So this is our plan. We put 4 screws and at the proximal and distal foundation, and alternate pedicle screw in between the proximal and distal foundation. The UIV T2 at the end of surgery is aimed at 0 degree. So under general anesthesia, we will put a crossbar and to try to measure the UIV tilt angle before the surgery. The UIV tilt angle under GA before the surgery using the crossbar is +7 degree to the right. And our aim of the surgery based on calculation, the final post-operative UIV T2 tilt angle target must be at 0 degree. So how do we achieve this? So the surgical strategy listed are maximal correction of the proximal thoracic curve, followed by harmonious correction of the main thoracic curve, and occasionally we will perform letting go of the main thoracic curve if the proximal thoracic curve is too stiff. And finally, most of the time for severe lanky 2, we may unify the main thoracic and proximal thoracic curve into a single thoracic curve. So again, under GA is +7 to the right 7 degree. At the end of surgery, we like to achieve the UIV T2 final target 0 degree. So I will illustrate it using a diagram and also a surgical video. Please pay attention on the yellow UIV tilt over here. So let's begin. So the UIV tilt begins with the +7 degree to the right. We usually insert the right rods first to address the concave of the proximal thoracic. So the first, we have to bend the rods We measure the rod, and this is how we bend the rod. Hyperkyphotic for the proximal thoracic, a straight depending on the main thoracic status, and slightly kyphotic at the end over the thoracolumbar-lumbar junction. The hyperkyphotic and the kyphotic bending is to create a high rod contouring angle. So why a high rod contouring angle is important? A rod contouring angle over the proximal and distal portion of the rod is important to reduce the pull-out force from the UIV and LIV screws. Practically, by having a high RCA, one should be able to transfer the pull-out force, all right, from the UIV and LIV screw to the screw before the UIV and LIV screws, as shown in this video. So the reduction mainly performed over the screw before the UIV, and so therefore the UIV will have a soft landing. The main thoracic side, the rod will be straight, used to reduce the rib hump. And occasionally, we actually leave the screw proud so that we can further compress and reduce the rib hump. So when the rod inserted over the right side and correction of the concave proximal thoracic, once we will notice that just by inserting the right rods, the UIV tube from +7 will reduce to +4. Following that, we will distract the concavity of the proximal thoracic curve to bring the UIV maximally to the left side. This is done by tightening the UIV screws, and following that, using a compressor as a distractor to distract the proximal concave thoracic curve. And now you notice that by doing maximum distraction of the concave of the proximal thoracic curve, the UIV tilt angle has gone to the negative zone. If you feel that the UIV tilt is still not enough for this case, one may let go the spine. So letting go of spine means that it's further bending the rods to bring the UIV to the more negative region. And once this is done, reduction and compression on the convex main thoracic curve is performed to achieve a coupling effect and to cantilever the rib hump downward. By doing so, correction of the main thoracic curve will swing the UIV tilt So once the reduction and compression of the convex side is done, next is that we will start to insert the left rods. Bending of left rods is by hyperkyphotic. And by inserting of the left rod into the system, one will notice that again, the UIV will tilt to the positive zone. But this issue can be solved by compression on the convex proximal thoracic curve to bring the and fine-tune the UIV tilt from the positive zone to 0 degree. And by doing so, one able to control the UIV tilt to 0 degree, and this is confirmed by checking using a crossbar. So a crossbar, UIV tilt and T1 tilt angle can be confirmed intraoperatively by using a crossbar with the help of the fluoroscopy. And UIV tilt is confirmed to be 0 degree. And very important that the UIV tube angle can be assessed intraoperatively before, during, and after performing the correction maneuver by visualize directly before checking with the crossbar. So pre and post-op radiograph showing a good correction of PTC and MTC, good pre-operative post-operative lateral radiograph, and clinical photo show a good medial shoulder and neck balance. Now I go to a clinical case study number 2. In clinical case study number 2 is still a Lanky 2 case. This is a Lanky 2 AR curve, and again, because of the large main thoracic curve, following correction of main thoracic curve, this type of curve will always result in medial shoulder and neck imbalance. In this case, main thoracic 65 corrected to 34, proximal thoracic 37 to 29. Conventional UIV and RV selection is T2 and L3. So we calculated the optimal UIV tube angle for T2 is 0 degree. So easy to balance. However, we notice that for this case, T3 optimal UIV tube is -5. And we think that it's feasible, all right, to stop at T3 instead of T2. So the calculation of optimal UIV tube angle for this case at T3 is right side bending 10 degree, left side bending 0 degree. So therefore, the optimal UIV tube angle is -5 degrees. So our selection is UIV T3, tube angle -5 to the left. So before correction under general anesthesia, the UIV tube angle is +5 to the right. And surgical strategy is the same as the case number 1. After correction, the UIV tube angle is -5 to the left. We further confirm with the crossbar to make sure UIV T3 is -5 degree to the left and T1 tube 0 degree. This is a pre-op and post-op 18 months follow-up, and the T3 tube is still at the negative zone, and the patient has a good medial shoulder, neck, and lateral shoulder balance. So we are able to achieve this and avoid these imbalances. So for completeness sake, let me share with you a clinical case study of a simple Lanky 1 flexible. So for this case, it's a 16 years old, Lanky 1 AN, main thoracic 56 to 13 degrees, proximal thoracic 12 to 7 degrees. In this case, we selected UIV as T3, and the calculation of the optimal UIV tube angle T3 is as follows. Right side bending 9 degree, left side bending -1 degree. So therefore, the optimal UIV tube angle for T3 is -4 degrees. -4 degrees means 4 degrees tilted to the left. So our school planning followed by the UIV T3, the target is -4 degrees at the end of the surgery. Under general anesthesia, because it's a Lanky 1 flexible case, the UIV T3 tube angle is -17 degrees to the left. And this is totally different from the case 1 and case 2 that I shared before, where the under GA is at the positive side. So our aim is to achieve a final target -4 degrees to the left. So the strategy is totally different. In this case, we maximize the correction of the main thoracic curve to achieve the targeted UIV tube angle, so that we can get -17 to the left UIV tube to achieve -4 degree UIV tube angle. How do we achieve this? Again, we look at the yellow UIV tube angle. Under general anesthesia, it is tilted to the left 17 degrees. So to bring it to negative 4 degrees, so what we need is to insert the left rod in, just like any standard reduction of the main thoracic curve scoliosis. By inserting and distracting the concave main thoracic curve, one should be able to bring the UIV tilt angle from negative 17 most likely to negative 7 degrees, for example. Following that, we can insert the right rod, convex rod, over the main thoracic to further compress to bring the UIV tilt angle to the targeted region. In this case, it's negative 3 degrees. So we put a crossbar to check the T3 UIV tilt angle, and the UIV tilt angle in this case is negative 3 degrees. And pre and post-op corp angle correction, lateral view pre and post-op, and clinical photo pre and post-op. Now I would like to go to lateral shoulder imbalance. For lateral shoulder imbalance, at this point, we do not have a solid solution. Akil and Carrick have reported that 28% of normal adolescents have asymmetry shoulder. How to achieve a lateral balanced shoulder post-operatively remain unclear. Brooks and colleagues have reported that even selection of T2 UIV does not guarantee a post-operative shoulder balance, RSH, which represent lateral shoulder balance. Why we have difficulty correcting lateral shoulder balance? Reason being that it's impossible to manipulate the T1 or T2 and hope that we can affect and change the posture of the lateral shoulder region, which is located far away from the spine. So, are there any solution for lateral shoulder balance? At this point, the answer is no. But what we know is that lateral shoulder asymmetry changed significantly from pre-op up to 6 months post-op surgery. And majority of patients will have improvement in their lateral shoulder balance in 2 years post-operatively. Professor Masumoto has published that distal adding on may be a form of compensatory mechanism for PSI lateral shoulder imbalance. Conclusion. At this point, we know that there are 2 types of shoulder imbalance: lateral shoulder imbalance and medial shoulder imbalance, which occur together with neck tilt. For lateral shoulder imbalance, it can occur in normal population. Spontaneous correction can occur during post-op follow-up. Distal adding on might be a form of compensating mechanism that help. Medial shoulder imbalance together with neck tilt. Beside UIV selection, an optimal UIV tilt angle is important to level the T1 tilt. So for this issue, nowadays, we already have evidence from literature how to select the UIV selection. And with the proper UIV tilt calculation, one should be able to avoid the post-operative shoulder imbalance in scoliosis surgery. Again, thank you very much to the Pediatric Spine Academy India for the invitation. Thank you.
Thank you, Professor Kwan.
Yeah, welcome, welcome.
Thank you for a very interesting talk. and the effort taken by you to make it simple and understanding.
Welcome.
KV?
Professor Kwan, that was an absolutely amazing talk. I loved every minute of it. It was really beautiful. Can I ask some questions?
Yeah, sure.
So one of my question is, how accurate are these measurements? I mean, even with digital measurements, variability of 1 degree, 2 degrees, 3 degrees, 4 degrees is, I mean, how accurate is it? Because how reproducible is it? Because many of your measurements, I can understand a 17 degrees, a minus 17 degrees being close to reproducible, but a minus 1 degree or a minus 3 degree, 4 degree, 5 degrees, how reproducible it is. The next time I measure it, or next time you go back and measure it yourself, it might not be 1 degree, even with digital measurements. That's one of my questions. I'll just finish all the questions that I have, and then you can start answering. The second question is the value of intraoperative radiological measurements. Why I'm asking this is the patient is under anesthesia, and you are using forceful manipulative measures like, pushing the rod down, cantilevering the rod down, derotation maneuvers, which are forceful maneuvers. And under anesthesia, the patient is likely to tilt the body this side, that side. So how valuable are these? How well do they correlate with postoperative standing X-rays and MRI? So these are my main concerns. So as a general rule, I don't take any intraoperative radiological measurements for these reasons, because if you tilt the patient this way under anesthesia, that's your tilt. If you tilt it this way, that's your tilt. So that's my understanding. Can you explain, please?
Yeah, thanks, Menon. I think that your question is very relevant. So for the first question is that I'll go to the second question first. How reliable is the UIV tilt angle and LIV tilt angle under general anesthesia, and compare with post-operative UIV and LIV tilt angle? We actually did the research, and that was published, I think, about 7-8 years ago. We found that the correlation of the UIV tilt and LIV tilt angle under general anesthesia correlate very, very well with post-operative UIV tilt and LIV tilt angle. And this was published in the Clinical Spines, Clinical Surgery, CSS. So we strongly believe that whatever you measure from the under GA using the crossbar will be representative post-operatively. That is for your question 2. For your question one is how is the intra and inter-observer reliability for measurement of the UIV tilt angle. We actually did a study when we published the paper. The reviewer requests us to answer the same question. So we ran through the intra and inter reliability to measure the optimal UIV tilt angle. And surprisingly, the tilt angle is 0.8 above. Yes, very, very good. For those, we have this scoliosis operative course back in our hospital, and every 2 months. And when the participant come over, we always divide the participant, give them cases for them to measure the angle, and at the end we compare the angle. Surprisingly, the error maximum error is 2 degrees. So that brings a very important point. When you calculate the optimal tilt angle from the left and right side bending X-rays, you have a target to work on. Let's say you have a T3 that's supposed to tilt to the left 5 degrees. Plus and minus 2 degrees is not an issue. But what the surgeon need to know is you cannot park a UIV T3 that's supposed to go to left 5 degree. You park it the opposite right 5 degree. that will end up with a disaster medial shoulder.
Can I ask one more question?
Yeah, sure.
In the case number 2 that you showed us, the Lenke 2 curve,
Yeah.
Where you would normally have selected a T2, but instead of that, you selected the T3 as the UIV.
Yes.
So my question is, I mean, there's no real value in saving a motion segment in the thoracic spine.
Yeah.
Why do you really go to T3? I mean, if you had gone to T2 in that example which you illustrated, you just needed a dead horizontal T2.
Yes.
Instead of which you went to the T3 where you had to adjust the tilt a little bit, which is a bit bigger exercise.
Yes.
Why would you do that?
Thanks, V Menon. Actually, it's very rare for us to go to T3. The reason that case is because the T3 pedicle is very big. Over the right side, T3 pedicle is very big.
Okay,
so we want to stop at T3 just to prove a concept. Just to prove a concept that actually all of us, the deformity scoliosis surgeon, whichever level you select, you are okay. Yeah. You're okay. You can select T1, T2, T3, even up to T4. You are okay. You are all right. Provided the other important factor, which is tilt angle, shouldn't be neglected.
I get your point. Thank you.
I have a question here, Dr. Ajoy, if you allow me.
Yeah, sure.
Hi, Prof. Kwan, how are you?
Hi, Pankaj.
Prof, I've got one question for you. How do you ensure the structurality of the proximal thoracic curve? Because I saw in your case 1, case 2, the lateral shoulder height or the lateral shoulder radiographical angles or the clinical angles were similar. So how far you go for to look for the structurality of the proximal thoracic curve, and what extra measures you take? Because in a left-sided or a Lenke type 2, we expect the left shoulder to be higher up.
Okay. The good question, Pankaj. A very good question. In our center, the problem with us is that we perform a physician-supervised cervical supine side bending firm. It means that we send the doctors to the radiology department and forcefully, bend their neck to make sure the proximal thoracic curve are properly bent before the X-ray was taken. So it's a physician supervised. So therefore, we have X-ray taken by some radiographer before the doctor arrived, not supervised, and later supervised. What we found is that is an unsupervised X-rays, the proximal thoracic curve can be 30 degrees. But with the supervised proximal thoracic curve, it can be 20 degrees. So there's so much difference. So in our center, this case will be classified as Lenke 1 stiff. But in other center, if they do not perform cervical supervised bending firm, and this case will be Lenke 2. And so therefore, the surgeon will go to T2, for example. So to answer your question, how do you assess the structurality of the proximal thoracic curve? We perform a supervised cervical supine side bending firm. And we use this side bending, all right, to determine the structurality of the proximal thoracic curve. Instead that we have also have a paper published with regard of this aspect. What we notice is that Lenke 2, where the proximal thoracic curve side bending is 25 degrees above, whereas in Lenke 1, there are two subgroups. One subgroup is when the side bending less than 15, the other subgroup is more than 15. We name this subgroup proximal thoracic side bending between 15 to 24.9 as the Lenke 1 stiff. A Lenke 1 stiff. And this group is more dangerous than Lenke 2. Because in Lenke 2, you know there is a proximal thoracic curve. But in Lenke 1 stiff, it's a hidden structural proximal thoracic curve. And they usually have a flat T1 to begin with. And the surgeon thought it's a lanky one and straighten all out, and there's where the medial shoulder, will go off balance.
Okay. So all those measurements again are done on a supervised cervical bending
Yes,
films, yeah?
yes, right.
Prof, I have got one more question if allowed.
Yeah, sure.
Yeah. So is there any difference in your correcting maneuvers with regards to medial shoulder? I understand medial shoulder is primarily by compression distraction. That's what you do?
Yes, yes. The compression distraction must be planned ahead of time. We must correct the proximal thoracic curve and know how much reserve of correction of proximal thoracic curve we have before we manipulate the main thoracic curve. Because once you manipulate the main thoracic curve beyond the ability of the proximal thoracic curve to compensate back, then when you check an X-ray, the whole shoulder is off. Then you practically have to revise the whole construct again, and most likely it'll be difficult because the screw may be loosened at the time.
And is there any different correcting maneuver you use to balance out the lateral shoulder imbalance?
No. At this point, we do not have any maneuver for lateral shoulder balance. Instead, that we do not look at lateral shoulder balance. Reason being that the lateral shoulder has so much reserved motion, first of all. And sometimes, as you know, I think Menon have published the discordant shoulder. Occasionally, you have a lanky too with the T1 that tilted to the right, but the lateral shoulder is reversed. And we notice that it's quite common in lanky 2. It's up to 30-40% in lanky 2 cases. You have the T1 that's tilted to the right, whereas the lateral shoulder tilted to the left, and it's discordance. So in that case, in those are cases, we don't do a lateral shoulder to choose our UIV per se. We still look at the medial shoulder. But somehow, our data show that the lateral shoulder will find its own way to balance back.
Is there, I mean, like, it does what you call derotation of the proximal thoracic help you correct the lateral shoulder? I'm just asking you, and you have any experience in that?
Yeah, a very good question, because I still remember Arvin mentioned about this before. So I looked through literature. What I noticed is that actually Professor Suk had published a paper that he tried to use the rotation of the proximal thoracic curve and hopefully reduce the harm, and so therefore reduce the medial shoulder imbalance as well as lateral shoulder. And what the result shown that is actually the rotation does not help in this aspect. The rotation of the proximal thoracic curve.
Prof, I got just one last question, and then I'll be off.
Fine.
Yeah. So we expect Lenke 1 having a post-operative residual shoulder imbalance to correct. We have a proximal thoracic curve, which may kind of can compensate at 2 years, as you rightly said. But in a Lenke 2, where you are getting all the correction intraoperatively and you don't have anything else to compensate higher up.
Yeah.
How do you expect it to get better at 2 years, as you were trying to say, the lateral shoulder balance?
Oh, it's a very good question. Yeah. My colleague, Professor Chu, have published a paper in the Spine journal, if you're not mistaken, about the conformity of the shoulder. So what we notice is actually in 5 years follow-up, main thoracic curve cases, the medial shoulder are very constant. It will not change. If let's say if you're good, it will remain good. If you're bad, it will remain bad. It will not change. Maybe for obvious reason, because you stop at T2, T3, so therefore it's pretty stable. But for lateral shoulder, the answer is no. It's not. It doesn't remain constant. So how to solve a lateral shoulder issue? The answer is, at this point, we do not have a solid or strong evidence, all right, to overcome this issue. What we know is that spontaneous correction can happen. All right. And our data show that too, spontaneous correction can happen. And it's not stable, means that sometimes it can be right side up, sometimes left side up. So depend on the follow-up period. Whereas the medial shoulder is pretty stable. However, the Hong Kong U have published another paper, very interesting. It said that in the event your T1 tilt is tilted 10 degrees or more, if I'm not mistaken, mean you have a very severe medial shoulder, 10 degrees or more, then your lateral shoulder will set in. And this lateral shoulder will not correct. Because obviously, because your medial shoulder is just too bad, the lateral shoulder, have set in. And this lateral shoulder is structural.
Thank you, Prof. That's all from my side. Excellent talk.
Thank you. Thank you.
Can I ask one more question?
Yeah.
You just mentioned that between Lenki 1 and Lenki 2, there is a Lenki 1 stiff.
Yes.
So doesn't that actually mean that our criteria for selecting structurality of the proximal curve may be inadequate? Proximal thoracic curve.
Yes.
Whatever criteria we're currently using for determining the structurality of the proximal thoracic curve are probably not adequate. That's why you have between the Lenki 1 and Lenki 2, there is a Lenki 1 stiff, as you described.
Yes. Our data show that the issue is like what Pankaj had mentioned just now. The way we assess the structurality is different from another center. So we are using a supervised cervical supine side bending firm. So to assess the proximal thoracic curve maximally. So based on our data, so we think that the current recommendation may not be adequate as suggested by KV, by you. The reason being that some of the Lenki 2, you actually can stop at T3. And some of the Lenki 1 stiff, you have to go to T2, to make the surgery easier. So the reason is because of the tilt angle. If you surgeon certainly do not want to stop at the UIV, where the tilt angle is to the left 10 degrees, because it's so much difficult to create the 10-degree tilt at the end of the surgery. So you rather go up one level higher to bring it to -3 degree, or even another level higher to become 0 degree. Because the higher to go, the more horizontal will be the tilt angle.
Yeah, understandable. Thank you very much indeed.
Welcome.
Any questions there in the
Yes, so we have Dr. Kwan, we have YouTube live that's going on, and we have one question from Dr. Atif. He's asking that do you do extra cervical side bending films for all, or it is just a part of your routine whole spine bending X-rays at your institution?
Oh, thank you. Yes, we actually perform the routine whole spine bending. So it's not only the cervical, it includes the thoracic and lumbar supine side bending. It means that the whole bending are in one firm. So it's not a separate firm. So the standard side bending is mainly the thoracic and lumbar. So the physician will be there to ensure that the cervical bending are being included into the bending firm. Thank you. I think this is a very good question.
May I ask a question, please? Ajay, can you hear me?
Please go ahead.
Yeah. So I'm not sure I missed the point, but I noticed that in case number 1, you inserted the right rod first. And in case number 2, I think you inserted the left rod first. So is there a criterion to decide where you're going to do the right rod first and the left rod first?
Oh, thank you very much. I think it's very relevant question. We are being taught that the way to address a deformity correction is over the concavity of the curve. So On the third case, it's a straightforward lanky one. So there's only one curve, which is the main thoracic curve. So therefore, the ref rod was inserted onto the concave main thoracic curve first to correct the main thoracic maximally to achieve the T3 tilt angle from -17 to -4 degrees. Whereas the first case is different. Because of the presence of the proximal thoracic curve, the right rod will be inserted first. Reason being that we believe that the right rod will address the concave of the proximal thoracic curve so that we can distract the proximal thoracic curve all out to bring the UIV T2 to the negative zone before we start to correct the main thoracic curve, which will bring the UIV to the positive zone, the danger zone, which is positive. So in summary, if you have a single main thoracic curve, a left rod will be good enough to address the deformity correction. If you have a double proximal thoracic and main thoracic curve, then the proximal thoracic concavity need to be addressed first, because proximal thoracic curve is always stiffer than main thoracic curve.
Thank you. Thank you for the excellent lecture as well.
Oh, thank you, thank you, thank you.
Any other questions, Hriday?
No, sir. That's it.
Thank you, Kwan, for an excellent lecture, as usual. I heard it many times, but still every time it's something new for me, and it's probably a revision for me to understand it much better. Again, thank you for joining us, and hope to have you on a different topic next year.
Yeah, thank you very much for the invitation again.
Bye.
Yeah, thank you. So before we end, this is the last session for this year, but we have interesting courses coming up by the Pediatric Spine Academy India in the next year to come. So we are almost to 2026, and after our first successful Pediatric Spine Academy annual congress, our second congress is in February 2026 from 26th to 28th of Feb with AIMS Delhi. The much awaited Scoliosis Week in Kochi will be there again in 2026 April. And the third, which has been, we have a lot of queries coming in for the virtual fellowship that's again coming up in 2026. So all the people or all the PSA associates who have been registered with the society will get updates on this course. So stay tuned and check your emails regularly. So thank you all, and thank you so much for being part of the webinars for this season. Hope you see you soon next year. And thank you to all the PSA members and Professor Kwan. Thank you so much.
Good night, Professor Kwan. Good night, everyone.
Yeah, thank you.